Bonjour.
Hello.
Hello.
We can hear you
me?
very good. Just a little moment to present, to introduce Sophie. Sophie is the coordinator of the French AA Amyloidosis Center, if I said correctly.
Yes.
The National Reference Center in AA Amyloidosis, and she is a big personality in the field of AA amyloidosis. Thank you very much, Sophie, for being with us today. The floor is yours. Thank you very much.
Thank you very much for your kind invitation. I'm very happy to speak today about what's new in AA amyloidosis in 2025. So I will speak a little bit about what is amyloidosis, but you all know it, so I will be quick. So in AA amyloidosis, we still have Congo red deposition with a birefringent polarized light, as you can see, with a green apple color. And in this variety, the kidney is really one of the targets of the deposition, and we have a good antibody against SAA in immunochemistry, which works well, better than in AL amyloidosis. So we can use this antibody, and we don't have to perform immunofluorescence on frozen biopsies. So just for you to remember, this amyloidosis is a multisystemic, and it's acquired. And today, in our countries, in Eastern countries, it's not very frequent, and it's the third most frequent after, of course, the wild-type TTR that you know, the AL amyloidosis. So that's the way it is. So in this amyloidosis, what is important is to know our enemy. What should we fight in this amyloidosis? So our enemy, sorry, I really like Star Wars. So our enemy is represented here by dark seed. So it's SAA. So SAA is this protein, which is called serum amyloid A protein. It's a protein with the same kinetic as C-reactive protein, but the only difference between those two is that if you have an excessive number of SAA in the blood, it will induce unfolded protein. The protein will not be folded correctly, and it will accumulate, and it will give amyloid deposition composed of SAA. And we don't have any amyloid deposition of CRP because CRP is not an unfolded protein. So that's the difference between those two proteins. This one has a problem of unfolding when it's in excess, whereas this one has no unfolding problem. So we only have SAA amyloidosis and no CRP. So in all inflammatory chronic situation, we can have a deposition of SAA. Also, it means that you have elevated SAA in all inflammatory process. But for some reason, we have amyloid deposit only in some situation and not in every patient. So in 2025, do we have novelties to confirm the diagnosis? So I told you at the beginning of the talk that we have the red Congo deposit staining and the immunochemistry of SA antibody. But what is new is that we can use mass spectrometry, so which is also called proteomics, to perform the diagnosis. So maybe during the discussion you will tell me if you have this available in Romania. Now, for example, in France, we have 2 hospitals that can perform it. And in the world, in the US, they perform a lot of proteomics, and also in England. So what's new about evolution? There's not a lot of novelties, unfortunately. What is severe in this amyloidosis is the progression to the kidney insufficiency, and when the patients have terminal end kidney failure with requiring hemodialysis, they have a worse morbidity and mortality, and the mortality rate increase. So really, in this variety, the most important organs to check is the kidneys, and we really have to follow them, I will say every 3 months by creatininemia, and urinary measurement every 6 months. The other organs are not very severe. For the cardiac involvement, it's very rare. So if at the beginning you don't have any problem, it means that you can just follow it clinically. Now I will show you this slide with all the etiologies of AA amyloidosis. So are there some novelties? I will say here in this etiologies with infectious disease, there is no novelties. It's always chronic infection, especially tuberculosis. Also, you will tell me if it's the most frequent in your country, but worldwide, it's the most frequent cause of AA amyloidosis. Then we have bronchiectasis, and it can complicate tuberculosis, or it can be alone. On the right, you can see maybe some novelties with the obesity, and on the left, you can see some very elderly known etiologies like inflammatory rheumatism, but they are decreasing. And for the autoinflammatory disease, the most frequent one is still familial Mediterranean fever, and Cyprian Jurkut just told you about some other rare etiologies there. So who can still develop an AA amyloidosis in 2025? The most frequent people are undiagnosed people with autoinflammatory disease, so they don't have any treatment, and that's exactly what Professor Jurkut just told you, for example, about those rare monogenic autoinflammatory diseases such as TRAPS or MKD, because they didn't know the patient they had the disease, they didn't know they had inflammation, so that's the reason why they can develop amyloidosis. Then we can also have patients that are non-compliant to the treatment. For example, in familial Mediterranean fever, if they don't take their colchicine. Also, we can have patients with several causes of inflammation, for example, one arthritis, and then tuberculosis and obesity. Or also, they can have a treatment which is not adequate because they still have elevated CRP and SAA. So all those reasons can induce AA amyloidosis. And unfortunately, in our country, we still have new cases of AA amyloidosis every month. So what are the objectives of the treatment in this amyloidosis? It's very important to have an etiological treatment because, as I told you, it's the SAA that will induce the deposition. We have to normalize the SAA rate. So I represented here a tap with water coming out. So it means that if the water is SAA, we have to stop the water in order not to have any more SAA deposition. So when we look again at all the etiologies, we can really find the type of treatment. If it's an inflammatory disease, we will propose some anti-inflammatory drugs, especially against cytokine. If it's infections, we will need antibiotics. And if it's all the other etiologies, we will have a specific treatment. For example, if you have Castleman disease, you will propose IL-6 inhibitors. If you have Hodgkin lymphoma, you will propose chemotherapy, etc. So I want to show you this, which is something known, but it has to be said many times. For example, in FMF, when they discovered that colchicine was efficient, it was in 1972, then they gave colchicine to all the patients, and they realized that with the time, the occurrence of AA amyloidosis in this disease was decreasing about from 30% to 10%. It means that if you treat the disease, the inflammatory disease, then you will reduce the occurrence of AA amyloidosis. Now I want to tell you about some less known etiologies of AA amyloidosis. One is primary immune deficiencies. So if you follow patients with common variable immunodeficiency, for example, if you are a hematologist, I know you are in the room. So be aware if they have a bronchiectasis, it's a situation that can induce more inflammation because of chronic infection, and then it can lead to AA amyloidosis. And in this case, AA amyloidosis is at about 22 years old, so it's very young, and there are a lot of deaths also. So this is something which is serious. So this is only a picture of bronchiectasis, so be aware of this. This is another patient with bronchiectasis that we took, and just to tell you, this one, he died, and this one also died. He died during the COVID pandemic. So I will speak a little bit to you about Castleman disease because you are hematologists. So Castleman disease without HHV8 virus can be very inflammatory, and it can induce AA amyloidosis. So in the world, we have about now 40 cases that were reported, and two interesting things. Firstly, it can be unicentric Castleman disease. So when it's unicentric, the treatment is surgery. If you take off the lesion, the Castleman lesion, then you will not have any more inflammation. And if it's multicentric, usually you have to give IL-6 inhibitors, and it's most likely in the abdomen because there is more space and the diagnosis is more low. Now, what about obesity? So now we like to say AA amyloidosis of unknown origin other than obesity. Maybe it's multifactorial. So we try to perform a lot of genetic exploration, but to date we don't have any clear etiology for those patients. So it's a work in process. We try to give them IL-6 inhibitors, and maybe in the future we will find new treatments, such as the treatments of obesity. And lastly, this is another kind of amyloidosis. It's amyloidosis of unknown etiology. So this category increased a little bit, and we still don't really know the best treatment, but from last works, it should be IL-6 inhibitors. So as you are maybe fond of genetics, I wanted to highlight here a rare etiology of AA amyloidosis with a mutation of the SAA1 gene in the promoter that can cause an hereditary AA amyloidosis. What is interesting here is that it's a mutation in the promoter of SAA1, so the patients, they don't have elevated CRP, but only elevated SAA. So this was the first paper, and there are a few more families that were described, and you can see it's a dominant disease, and to date, the most efficient treatment is IL-6 inhibitors. So we have spoken about the etiological treatment. Now we will speak shortly about the symptomatic treatment in this disease. So if you have a chronic kidney disease with a very severe function, you will go under hemodialysis. And one good news is that if you are with hemodialysis, you can benefit of a kidney transplantation. So kidney transplantation for AA amyloidosis is a good option, and usually the efficacy of the transplantation is good. Then, in this disease, you can also have diarrhea, so you don't have any specific treatment for diarrhea. And you can also have thyroid goiter, and sometimes if it's too big, you will need to perform surgery to decrease the goiter. So here is a paper about transplantation in patients with AA amyloidosis that was about the French multi-center cohort. And here you can see that in France, in the last 10 years, we had about 86 patients that had graft transplant. And for those patients, the median age was 49 years old, and they were in majority familial militant fever with a good graft survival at 5 years. So for the symptomatic treatment, I told you about diarrhea. You can give treatment that stop the stools. And here I show you a few pictures of thyroid goiter. This man had a compressive thyroid goiter, so he had to go under surgery to liberate the esophagus and the bronchite. And unfortunately, this man died a few years ago, so he had the etiology were FMF and tuberculosis. So now, in the next minutes, we will speak about the novelties and perspective before the conclusion. So in the last 5 years, there were a few novelties in this field, so more etiologies that we will see together. So some more genetic etiologies. I tell you for the infections, it's always the same that I told you. Also, people can have multiple etiologies. They can have some proliferative neoplasm, lymphoid neoplasm, and obesity. So what are the new genetic diseases that can induce AA amyloidosis? So I told you in the last slides about SAA1 polymorphism. And now we found out new monogenic autoinflammatory disease. So we can have ADA2 deficiency called DADA2. You can also have VEXAS with UBA1 mutation. If you are a hematologist, I'm sure you know about this disease. I will show a few pictures after. We have also a gene which is called ALPK1, and it can give a rare disease called Rosa syndrome. And this one, DOC11, can give thrombopenia, so maybe you hematologists could see this disease. And PSTP1 can also induce hematological abnormalities because it can induce anemia, deep anemia, and also it can induce pancytopenia. So VEXAS syndrome, I don't know if you are all aware of it, but I cannot prevent myself from speaking 1 minute about VEXAS syndromes because I know it's not a rare disease. And also in the discussion, maybe Cyprian and you can tell me how many VEXAS patients you have now diagnosed in Romania. So this acronym stands for vacuole in myeloid progenitors. It's linked with a mutation in the gene UBA1, which codes for E1 enzyme in the ubiquitin pathway. It's on the X chromosome, so it's linked, and it's an autoinflammatory somatic disease, a little bit like myeloid proliferation. So here on this picture, which is from a publication, you can see most of the features of the VEXAS syndrome, and this man could have amyloidosis. So it's usually elderly patients, more than 50 years old. It's in 95% it's men and not women. They are very tired usually, and they have those lesions here that can mimic sweet dermatosis, sweet syndrome, on the skin, everybody on the skin, on the face, on the arms, on the trunk. They usually also have palpebral edema around the eyes, and they can have in 35% ear chondritis. So this man, on this slide, I wanted also to show you, all hematologists, this palpebral edema, which is here very impressive. But if you have a patient with macrocytic anemia and palpebral edema, with inflammation, you will really have to suspect VEXAS syndrome. So now let's speak about etiology. So we still have all the same etiologies, so I will not speak too much about this because I've already done. And then I will just say that patients can display multiple etiology, not only one, so we have to be aware of that. And for proliferative neoplasm, it's not well published, but we have in France a few cases of histiocytosis, including Erdheim-Chester disease, that complicates with AA amyloidosis because they are very inflammatory. So you must not forget this entity, especially you hematologists. Then we can also have lymphoid neoplasm. So the most frequent one is Waldenström disease, hyperinflammatory Waldenström. The second one will be Schnitzler syndrome, and the last one is myeloma, hyperinflammatory myeloma. For obesity, I have already spoken a little bit before, so I will not speak more about obesity. And I will go to the perspective. So for the treatment, look here, I put all the treatment that were already given for AA amyloidosis. So we have IL-1 blockers, IL-6 blockers, and TNF blockers. I will go firstly to TNF blockers. It can be done in DADA2, so it's ADA2 deficiency. And in ADA2 deficiency, you can make the diagnosis in hematology because patients usually have cytopenia and hypogammaglobulinemia. They can also have lymphoma. IL-6 blockers are probably the most interesting molecules in AA amyloidosis when it's not linked to FMF or CAPS. It can be given in chronic inflammatory rheumatic disease. It can also be given in second intention in some inflammasomopathy when the IL-1 blockers don't work. It will be interesting in Still disease, Castleman disease. And for IL-1 blockers, as expected, it can be given in good, but AA amyloidosis is not so frequent in good. And you can give it in inflammatoropathy, like FMF cap straps, MKD, what already Cyprien Jurkut told you a few minutes ago. And you can try it in still a patient with unclassified systemic autoinflammatory disease, but don't forget IL-6 blockers that seem to be quite efficient. So what are the perspectives in this amyloidosis? The most important would be to adapt targeted treatment to etiology. So we really need to find the etiology of amyloidosis in front of every patient to adapt the most targeted treatment. Then for the patient with multiple infection, it's very hard to treat them, so we will have to find the best anti-infectious treatment. And the future, we will have to find new treatments for obese patients. So what are the challenges in 2025 on this variety? I just told you find new treatment. Maybe we will speak about genic therapy in some diseases such as ADA2 deficiency. We will, of course, hope new treatments targeting fibril, but it's a hope in all the amyloidosis variety, not only AA. And I told you about kidney transplantation, so that's something which is safe and very useful in AA amyloidosis compared to all the other amyloidoses. So I will finish with these sentences. So AA amyloidosis today, unfortunately, it has not disappeared because 15 years ago, we hope it could disappear with all the new antibiotics in the world, but unfortunately there are still cases. And the diagnosis is often too late. So Professor Jurkut just told you before that for the monogenic autoinflammatory disease, usually the AA amyloidosis diagnosis is done late and it makes the discovery of the other disease, but it's usually the case that the diagnosis is very late, about 50 years old. And then we don't have a lot of options to treat the patients. Also, I hope you follow me that there are more causes than in the past, especially the genetics. And unfortunately, also, the prognosis remains severe with about 25% of deaths, and we have deaths every year. So in this disease, we really need a good collaboration between the nephrologists, the internists, the hematologists, the infectiologists, the rheumatologists. And here are my key messages. So AA amyloidosis is still a diagnosis of elimination. The incidence decrease. We have the numbers in the UK, for example. There are less and less AA amyloidosis. Unfortunately, the diagnosis is met with a lot of delay, and also it may affect older patients. Example for the VEXAS syndrome. The etiologies are diversifying. And also something interesting is that the rate of SAA does not mean the presence of AA amyloidosis, because SAA is very ubiquitous, and so we really need to have a biopsy to see if there's AA amyloidosis. And we don't perform biopsy if there is no kidney insufficiency and also if there is no proteinuria. So the treatment targeting inflammation are powerful, especially the ones targeting IL-1 and IL-6, but we still have serious bad prognosis for AA amyloidosis, complicating infectious disease, especially tuberculosis and bronchiectasis. So on this slide, you can see all the collaboration with the doctors, and I could put some hematologists here also on the slide. And for example, in France, we wrote some French guidelines for the management and diagnosis of AA amyloidosis. You can find them easily on open access on internet, and it's in English if you are interested. And I thank you very much for your kind invitation and for your attention.
Thank you very much, Sophie. If you have some questions and comments, Professor Corrigo.
Yes, thank you very much, Professor, for this excellent presentation, a comprehensive presentation. My question is regarding VEXAS syndrome. This new entity, I'm hematologist. It's pretty interesting for me. I never saw. So what would be your advice regarding therapy?
Okay.
I mean, if you have a genetic mutation, and of course if you have a syndrome, myelodysplastic syndrome, and you have all of this tableau together.
Okay, so I will answer if a patient has a VEXA syndrome, but I will not say with amyloidosis because it's rare. So I will just say in 2025, what's the best treatment for VEXAS? We really have two situations. The first one is a VEXAS patient, not very severe, with like inflammatory at first and not too many hematologic problems. So for this patient, we will propose IL-6 inhibitors in first line, and in second line, of course, we will have steroids, and to spare steroids, we will propose IL-6 inhibitors, and in second intention, JAK inhibitors. Then, if the patient has hematologic disease, and then you are a hematologist, so I will not say too much about the hematological disease, but if there is an hematologic indication, we will propose azacitidine. That's our recommendation in France. And we will do our best to keep on as many azacitidine cures as possible to improve the biological markers, the hemoglobin, the thrombopenia, etc. And the graft is kind of dangerous because those patients have a lot of infections, especially leptospirose, legionellose, or the intracellular bacteria. So our first option would be azacitidine, and then discuss graft if the patient is young. And if we cannot give a graft, and also if the azacitidine is not well tolerated, we will keep on steroids. And another point, very important, is to prevent infection with Bactrim and acyclovir also. I hope I answered well your question.
Thank you very much. Thank you very much.
Just Sophie, sorry, just a little comment. As I know, we have 8 confirmed patients in Romania with VEXAS.
Congratulations.
But yes, as I know, maybe there are others. And another one with the very, very classical and typical clinical presentation. He's hospitalized now in our service, but with the negative genetic. We are a little bit concerned about this patient. But 8 confirmed and 1 VEXAS-like, maybe.
Yes.
And the last one, unconfirmed genetically, is treated by azacitidine and
yes.
cortico also. Yes. So if you have another question.
Hello. Thank you for your excellent presentation. I'm a gastroenterologist. My name is Sandika Bucurica. And I would like to know, how do you manage the gastrointestinal involvement in these patients? Because as I understand, you only think about it only if they have clinical manifestations,
yes.
And also only if they have renal impairment. If they don't have, you don't think, at this kind of involvement?
So if you perform autopsy in patients with amyloidosis, 100% will have gastrointestinal involvement on autopsy, but not all the time clinical features. So the most problematic clinical feature when it exists is the diarrhea. So if they have diarrhea, we give like loperamide. We try to give also some treatments that are given for diarrhea, but it's very hard. We try to eliminate digestive infection like Clostridium difficile. For some patients, we can also give fecal transplantation if there's too much diarrhea. We can try, but it's one of the most severe feature, the diarrhea.
Yes.
So we don't have any specific treatment, and we try symptomatic treatment, and then we usually try to speak with the gastroenterologist if they have any interesting option. But there is no specific treatment because usually it means that the depositions are there, and to date we don't have any treatment to disappear the amyloid plaque.
Thank you very much. But also I would like to know in, I don't know, live patients, how many are diagnosed with gastrointestinal amyloidosis, and if you perform on regular basis biopsies on EEGs or on the endoscopy examinations, or just only if they have symptoms?
Okay. Only if they have symptoms, because then if you perform biopsy, sometimes it can be bloody, and we know they will have amyloidosis. We know it before. So only if they have symptoms. And something interesting, if you suspect amyloidosis in a patient, but in the past he had endoscopic, for example, fibroesophageal or coloscopy in the past, like in the last 1, 2, 3, 4 years, you can take back the biopsy and perform the immunohistochemistry staining with SAA. Then, if you find deposition of SAA, you'll say, oh, there's amyloidosis. We don't have to perform new biopsy because you know there was, so there will still be, you know.
Okay, and also, how many cases of ileus do you have in those patients? Besides diarrhea, because also the ileus is very hard to treat.
Yes. I don't have the numbers, but it's rare. So I will say maybe we follow about 300 patients with AA amyloidosis, where maybe 3, 4, 5, it's rare. And some of them died because of too much systemic features.
Yes. Thank you very much.
Hello, I'm Anca Bobirca. I'm a rheumatologist from Bucharest. Thank you for your excellent presentation, and thank you for the very nice publication regarding the transplanted AA amyloidosis patients. And I have a question regarding the tapering. Given the risk of infections, opportunistic or hospitalized infections, when to taper canakinumab or anakinra in this kind of population? Thank you.
Okay, so for IL-1 blockers, the infectious risk is very, very low. And if I am provocative, I will say there is no risk.
Okay.
I mean, the benefit is largely superior to the risk. And it's very, very rare to have. We have a little bit more infection with IL-6 blockers. But all the time, we have to study the benefit and the risk and to adapt. And it's rare that we stop the biotherapy. The only situation where there is a lot of infections is bronchiectasia. But sometimes IL-1 blockers, they modulate the bronchus, la paroi, je sais pas comment on dit, and there is less infection, so it's not so bad. And I will say the disease where we have the most infections is clearly VEXAS. That's the reason why now we really propose to give to VEXAS patients cotrimoxazole Bactrim and aciclovir Zelitrex to prevent those infections because when they have steroids and IL-6 or JAK inhibitors, they may have infections because per se VEXAS induce more infections.
Okay, thank you.
There are other questions? Just to finish, a provocative question. Should we test all obese people for SAA?
No, but we should perform a urinary bandlet. So is it a word
yes.
used? Because it's cheap. And once a year, when they have a blood test, you can check creatinemia. And then you perform a urinary bandlet. Because AA amyloidosis will only be found if you have kidney insufficiency, more or less proteinuria, but not if you only have elevated SAA, because all obese people may have elevated SAA, and SAA is ubiquitous and doesn't predict AA amyloidosis. Did I answer well, Cyprien?
Yes. Thank you very much. Other questions? Thank you very much, Sophie.
Thank you.
we will move forward. Thank you very much, and see you next time. Thank you very much.
Bye.
Bye.